glomus jugular tumors, again there is 4 types depending upon the extension. So basically glomus jugulare are from the jugular fossa, and it can involve the middle ear and mastoid, and also this will go infralabyrinthine area involvement up to the petrous apex, and also intracranial involvement. So in involvement of if it is type, so here the target area is around the jugular foramen, that is the skull base. Okay. So in type 1 and 2 there is limited involvement of the jugular fossa along with the infralabyrinthine segment and also the tympanic segment of internal carotid artery. This area. So here will be the target area in case of type 1 and 2. Okay. So glomus jugulare type 1 and 2. We have already discussed the various types according to Glasgow and Jackson, and also fish classification in the previous class. So in type 1 and 2 there is limited involvement of jugular foramen, infralabyrinthine compartment, and also internal carotid artery tympanic segment. So this much area is the target area. So the exposure should be adequate. So the door of entry is usually we are giving the post-oral transmastoid. Okay, so incision is usually post-oral incision, extended post-oral, that is 6 cm from the post-oral groove, and it is extending to the neck and also superiorly, and an anteriorly based flap is kept. This incision is for easy harvest of temporalis fascia if we need any reconstruction. Okay, so a post-oral incision 6 cm behind the post-oral groove, extending inferiorly and superiorly, making an anteriorly based flap, so that we can expose the structures in the neck. Okay, and also adequate exposure of the mastoid will be obtained by this. So in type 1 and 2, first put the incision, then expose the cranial nerve, especially cranial nerve 7, 9, 10, 11, 12. They are exposed up to the skull base, and also the important vessels are identified. After that, internal jugular vein is ligated for getting an easy exposure. After that, do a complete mastoidectomy. So this is post-oral transmastoid. So after doing a complete extended, or whatever you call, a mastoidectomy, but the posterior canal wall is preserved. Okay, it is after preserving a posterior canal wall. So you do a complete mastoid exploration, and the posterior wall of mastoid is related to the sigmoid sinus. So the lateral sinus is exposed from the transverse sinus up to the jugular bulb. Okay, then this lateral sinus is opened and the lumen is occluded using Surgicel. That is also to get a better control of bleeding. Okay, after doing that, next is facial nerve identification and exposure of facial nerve from second genu. It will be almost here, the vertical part from second genu up to the stylomastoid foramen. So doing a post-oral incision, then a complete extended mastoidectomy, then opening of the lateral sinus from the transverse sinus up to the jugular bulb and occluding the lumen of the lateral sinus, then skeletonization of the facial nerve from second genu up to the stylomastoid foramen. After that, go for a facial recess, extended facial recess approach. So drill an extended facial recess, and after that we want to get access to the tympanic part of internal carotid artery. So after doing an extended facial recess approach, drill the anteroinferior part of the external auditory canal. Drill the anteroinferior part. This part of external auditory canal is drilled so that we can reach the tympanic segment of internal carotid artery also. So after that, visualization of the tumor and removing it from the jugular bulb, internal carotid artery, and also from the cranial nerve, and removal in toto. Okay, so that is called a conservative jugulopetrosectomy. Okay. Jugulopetrosectomy. So for type 1 and 2 we do a conservative jugulopetrosectomy. That is by doing a post-oral incision, doing a complete mastoid exploration, mastoidectomy, extended mastoidectomy by preserving the posterior canal wall. Then identification and skeletonization of the lateral sinus from the transverse sinus up to the jugular bulb, and then opening and occluding the lateral sinus. Skeletonization of the facial nerve from second genu up to the stylomastoid foramen. Then doing a extended facial recess is drilled, and then the inferior wall, anteroinferior wall of the external auditory canal is drilled out to get access to the tympanic segment of internal carotid artery. And after visualization of the tumor, it is removed from all the areas, especially from the cranial nerve, and then getting a hemostasis and closure, which is called a conservative jugulopetrosectomy. In case of medium to large tumors, that is type 3 and 4, please refer the earlier part of this class. 3 and 4, mainly the tumor has extended out of the temporal bone, or if we need the we need to tackle the internal carotid artery, mainly the cavernous segment. Okay. In that case, we need an extended infratemporal fossa approach. That is infratemporal fossa approach and its various extensions. So that we can tackle the tumor when it is in the deep recesses of the temporal bone, and also if it has involved the clivus, then the cavernous sinus, then the nasopharynx, nose and the nasopharynx, and also the anterior, middle and the posterior cranial fossa. Okay. And posterior cranial fossa can be approached by the modified infratemporal fossa approach and its various extensions. Okay. And in this case, the incision as well as the steps are similar to that of type 1 and 2, and extra. The additional thing we are doing here is, one is external auditory canal. This external auditory canal is transected and it is oversewing, so that the content of external auditory canal, the tympanic membrane and also the content of the middle ear lateral to the stapes is removed. And this is our working plane, that is a skull base. So we have to remove the mandible. Mandible is retracted or dislocated anteriorly and inferiorly by removing the anteromedial ligamentous attachments. And if we need more of an anterosuperior extension, we have to remove the temporomandibular joint unit and also the zygoma. Okay, and after that the eustachian tube is permanently transected, and the facial nerve long mobilization. The other case it was a short mobilization. Here we have to do a long mobilization of the facial nerve. Okay, so that all these areas are well exposed and the tumor can be resected from all these parts. So this is modified infratemporal fossa approach, and if we need various extensions can be done on this. Intracranial extension of the tumor was once taken as a criteria for unresectability. But nowadays this intracranial extension is not taken as a contraindication. It is usually done as a single unit. Along with the tumor, this intracranial extension is also removed. And intracranial extension is defined as the extension of the tumor transdurally, that is through the dura into the subarachnoid space. So transdural extension of the tumor into the subarachnoid space is taken or defined as an intracranial extension. So in that case it is taken along with the primary tumor, and these are the stages of surgery for intracranial extension. That is, one tumor is dissected from internal carotid artery or from the infratemporal fossa. After dissection, it is debulking from the temporal bone down to the dura. Then removal of the intracranial extension as single unit, and there is reconstruction of the defect. So these are the 4 stages of surgery for intracranial extension, and this is done as a single stage operation along with the primary or along with the tumor in the temporal bone.